And we're back with another episode of On the Record with Tiffany. And today I have my special guest, Dr. Richard Gibney. Dr. Gibney, will you tell my audience a little bit about yourself and what you're doing now?
Well, let's see. I've been a practicing nephrologist for 43 years. I trained in the University of Texas Health Science Center, San Antonio. Was there for 5 years in the mid 70s. Then came to Waco, Texas. We grew from one patient up to about 800 patients now, and 11 dialysis units. And
Wow.
so we do a lot of different stuff. Got very connected with IHI, Institute of Healthcare Improvement, about the whole concept of I would say to you, how do you empower patients? How do you do continuous quality improvement? So we went from being, I would tell you that we were probably about average as far as our results, as far as quality and outcomes.
Mm-hmm.
And now we're the best in the country. We do it better than anybody. So in April of 19, I retired from the group and said, I'm going to spend my full time going around telling people about the opportunities available. And then, of course, that was April of 19. So then in March or February of 20, the coronavirus hits, which really kind of it's a terrible thing and it's awful and there's no question it's a bad thing, but we were forced to kind of step back from what we were doing and say, maybe there's something we can do that's even going to be better than what we're doing now. What we were doing, even though we had made huge improvements in quality, huge improvements in outcomes, there's always opportunity for doing things better. So I would tell you that the latest thing we're working on is that this kind of will set the tone for the entire talk we have. That before the pandemic, we used to always have in-person meetings. So if you had a medical meeting, a whole bunch of people, small, medium, big size would go, and then you'd have periodic breaks. And so going back in time, you go to that in-person meeting, and then they have a break, and then the story goes something like this, that three of the doctors thought, well, let's walk down to the lake that was close to the convention center, and were walking down, and we got closer to the river, and they heard people going, help, help, help. People were obviously in distress. So the three doctors ran down to the river, and the first doctor was a general surgeon. He jumped in the water immediately to race out and help somebody to come back to shore. The second doctor was a kidney doctor, nephrologist. And the nephrologist took out some 3x5 cards and was kind of coming up with ideas on what he thought would be the best way to save all these people. And then the third person was a family practice doctor. And the family practice doctor, she started to run upstream, up the riverbank, going upstream. And the other two doctors said, what the heck are you doing? And she said, I'm going to go upstream to find out who's throwing all these people in the river to get them to stop, and then we can make some real progress.
And that's a good analogy.
It shows you how wise primary care doctors are, that let's go upstream. So instead of having a disease-focused system, which is how much disease can we have, and then we take care of it after it's become disease, what if we went upstream and we tried to figure out exactly what was going on? And a good example of this is, I've seen this recently, the ASN, the
American Society of Nephrology.
American Society of Nephrology had a week-long meeting, and if you looked at the stories that were clinical dialysis stories, there were a lot of papers on the idea that we should consider trying to identify which patients were at risk, and also then to do education for them. That would be a good idea to try to help make things better. And the truth is, yeah, to identify people and to educate is a good idea. The one thing that's kind of made me very uncomfortable was, if you look at the data from the US RDS, which has been there for 50 years,
Yep.
and you say, well, what about them? Well, they've been publishing their data for 50 years, and guess what? If you look at the most recent data, which has basically been the same forever, 92% of the patients that have stage 1 through 3, CKD, meaning chronic kidney disease, means that their GFR is between 90 and 30 cc's per minute. So if you've already lost over a third of your kidney function, that's how significant your loss of kidney function could be. And 92% of the people are not aware that they have some kind of kidney problem. And you'd say, well, wait a minute, how did the US RDS get this data? These people had to go somewhere, someplace, sometime, and have blood work drawn, because otherwise, how can you have a GFR? Mm-hmm. So all this data was available, but somehow the ability for our system to communicate that to the patients and say, maybe it's lab error, maybe it's a minor problem, maybe it's a medium problem, maybe it's a serious problem, somehow we couldn't do that.
So let me get this straight. So you go get a test, you've gotten your blood work done, and I'm looking at it. I'm on staff. I'm looking at it at this doctor's office. But for whatever reason, that the fact that you've lost a third of your kidney function isn't communicated. Somehow we're missing communication somewhere in there.
Correct. And it's ironic, and this is another good example of how many good things that are happening. In 2016, Obama passed the CARES Act,
mm-hmm.
C-A-R-E-S, CARES Act. Mm-hmm. That was 4 years ago. And the CARES Act basically said two things. It said you should have interoperability, meaning that if you go to Methodist Hospital or the Baptist Hospital or University Hospital, all that should be available together. It shouldn't be, well, we can't find that information because it's not part of our system. So that's that whole concept of interoperable.
All systems should be talking to one another, should be able to communicate.
All be connected, so that if you came to a different hospital, they just have to pull it up on the computer and they can see all the data from the other hospital, so they don't have to repeat things, or they'll know exactly what was going on prior to arriving at your hospital. So that's the issue about interoperability. The second issue was patient access to their data, meaning are the patients allowed to see the notes of the doctors and nurses and everybody that takes care of them? Are the patients able to see their lab work and their x-rays? And of course, the answer is no, because you have this complicated system where frequently the doctor has to see it, and then the nurse has to see it, and then somebody else has to put it in the computer. So even though you may have a patient portal or a way to do it, the hospitals and the doctor's offices and everybody was not very good at, they just didn't do a very good job of getting it there. And I go back to the CARES Act from 2016, because effective today, November 2nd, after multiple barriers were put in place for this to become a reality, today it's a reality. So today you're going to see that all these different systems, they are going to communicate. And so when you go to a different hospital and say, well, I was sick somewhere else, and can you get that data to make it easier to find out what's going on? It's available. Or the same thing, the patient, we're going to make it easy for them to look at their data. So let's say, for example, you get to see it At the same time, it becomes available to everybody in the system. So let's say you have some tests done and it shows that you have gallstones. You can call your doctor or the nurse and say, listen, gosh, I didn't know I had gallstones. And they'll say, gee, we haven't looked at your lab work or your x-ray yet. So, oh yeah, that's right, you do have gallstones. The point being is that we want to make this a partnership. We want to make it a collaboration. So the smartest, the best, the goodest people, good, smart people in America, they're there to help themselves and to help you. So the people that in the past have been afraid about this, and they've always said, oh, this is, we can't do this because, it might be shocking or it might be whatever. But if you hide it by accident from people so they don't know about it, then how can the patients help themselves? And so what we found, which is changing rapidly, and this is why everybody should be excited, everybody should be thrilled, everybody should be pleased that the least utilized resource in medicine historically has been the patient. And that's all going to change now. And so that's a good thing. And that's happening at a time when you have this pandemic. So the timing is good because the timing is good. 4 years after Obama passed this legislation, it's going to become reality. Sometimes it takes a while to get through the barriers. The second thing is, saying that, the most powerful resource that we've found is the patient. The patient's the most powerful. Why? That's the person with the problem. That's the person that has the challenge or the difficulty. If you will share that knowledge with them and say, here's kind of what's going on, they'll do marvelous, fabulous things. They can't be expected to help you if they don't know about it. So we got to make sure they do know about it. And we can do a better job at that. And then finally, the person, also known as a patient, but the person with the problem has to be part of the solution. So if I say to you, Tiffany, well, you have blah, blah, but don't worry about it. We're all going to get a bunch of other people to do it for you so you don't have to be involved in the solution. You'd say, I don't know if that's going to work because I'd like to be involved in figuring out about high blood pressure or diabetes or kidney trouble, whatever it is. You will come up with better suggestions. So the idea is this is a magnificent time for us to take the most valuable resource, the patient, and say, you know what, we're going to change our process. And again, realizing this entire time, the doctors are all good, the nurses are good, the patients are good, so you've got a nice system where all the people involved are fine. But the process or the system we had just wasn't quite right to get the information to people. And then the question is, once the people, what do you do with them then, once you actually, and that's the next part of the talk, is that, what do you do once the people, if I say to you, gee, we found that you have, for the first time, high blood pressure, Tiffany, then what do we do?
Dr. Gibney, thank you for that information. And to my listeners, everybody that has high blood pressure, diabetes, everybody that's going through a chronic illness, come back and listen, because what Dr. Gibney is sharing is something that we need to know, that we now can be a part of what's going on with our health and with our bodies and with the next step. We really are all in this together. And you've been listening to On the Record with Tiffany.